Okay, well, good morning. Thank you very much for the invitation to come and present about Eucapnic voluntary hyperpnea. Thanks to Stefan and Benjamin for the invitation. Thanks to Ganshorn for the welcome and looking after me over the last couple of days. So I've been using Eucapnic voluntary hyperpnea for around about 20 years with athletes in the UK. And to evidence that, I've got a nice picture of me when I was young and looking much better than I do now. And I've used it working with a variety, a number of athletes, whether they be Olympic athletes, professional athletes, but I've also used it with recreational athletes and also children and more elderly people. So it is a test specifically trying to diagnose exercise-induced bronchoconstriction, but it's not exclusive to elite athletes. And what I'm hoping to do today is to talk a little bit about the assessment and how it might kind of fit within the assessment of an athlete who might be reporting respiratory symptoms. We're going to demo it, so we've got Ganshorn's equipment here, so we're going to demo it, and we're going to maybe talk about kind of how it might link to using, or how we might use spirometry before and after it, but also how we might use a new technology like oscillometry that might be the future pre and post testing as we go forwards. And just a bit of a self-promotion, I've edited a book which is all about supporting athletes and their respiratory issues, and a large kind of focus of that is where EVH testing sort of fits in that. So if you're interested about kind of reading more about this book's quite a good start. So I'm just going to start with a video about an athlete that might present to a clinician, and an athlete might be sort of presenting with these type of symptoms. Hope you got a bit of sound. You turn the sound up.
You stand up for me. Stand up, just look straight. Stand still, look straight ahead.
So this athlete's basically reporting that she's short of breath, tight-chested, can't complete high-intensity training sessions. And this is quite often that an athlete might go along to a primary care practitioner or present at secondary care, and basically you're presented with this, and it's kind of, well, what do you do? So symptoms might include wheezing, might tight chest, might be coughing, might be difficulty in breathing. Now, the problem, if we just simply go, well, you're short of breath, you've got no other respiratory problem, no other health problems, you're short of breath, it's probably asthma or exercise-induced bronchoconstriction, so have an inhaler. The problem is if we use symptoms alone, we get the diagnosis wrong 50% of the time. So we have to do some sort of objective testing to kind of figure out why the athlete is short of breath when they start to exercise. The reasons why somebody might be short of breath can include things like cardiovascular disease, could be physical limitations, so especially when someone's maybe not been active, it could be coming back from an injury, it could be kind of moving from sedentary to maybe more of a active lifestyle. We might see some symptoms present then. It could be because of an allergy, but the majority of people that I see, it's usually down to asthma or exercise-induced bronchoconstriction. Could be down to a disordered breathing pattern, or it could be down to an exercise-induced laryngeal obstruction. Now, without doing objective testing, it's very difficult to differentiate between those three things, and that's kind of where this kind of assessment allows us to help support the athlete and make an accurate diagnosis in a short period of time, and then obviously support the client efficiently. So if we're looking to think about we might use an EVH challenge to either rule in or rule out a diagnosis of asthma or exercise-induced bronchoconstriction. If you're not familiar what exercise-induced bronchoconstriction is, it's kind of part of I call it the asthma family, but effectively what it is, it's a narrowing of the airways, limiting expiration following a bout of exercise. It usually occurs following a bout, but it can occur during, but most of the time it's afterwards. A lot of the time, athletes fail to report symptoms, or if they do have symptoms, they fail to recognise the symptoms to be linked to EIB. And generally speaking, around about 80 to 90% of people with asthma also have exercise-induced bronchoconstriction. And so exercise or using something like EVH is a very good way of diagnosing the condition, but also monitoring the condition once you've started treatment. And I'll show a few examples of that later on. There's a very simple pathophysiology of how EIB develops. I'll try and simplify this for you just to kind of keep it simple. So we think about how EIB develops. When you start to exercise, you start to change the passage that air comes into your lungs. So if we're all at rest, we're all sat here breathing through our noses. When we start to exercise harder, we switch from being a nasal breather to a mouth breather, and we breathe more air in. What that means is that our lower airways have to do the humidifying and the warming and the filtering of the air. So if we're breathing that type of air in, we're basically going to need to lose water from the airway surface liquid to humidify the air. That then causes a dehydration process in the airway, in the lining of the airway. That dehydration process causes an inflammation process, and that inflammation causes the bronchoconstriction. So, and that's basically told on the left-hand side of this figure. So that's kind of simply how EIB occurs. Now, there's different types of phenotype of EIB, which can also include things like an allergic response as well. So there's not just one way so there's not just one kind of phenotype of EIB, just like there's not one phenotype of asthma. And so it can get quite complex as to what might trigger off an asthma or an EIB response in an athlete. It could just be simply dry air, but it might also need chlorine, it might need pollen, it might need pollution to also trigger it off. So it can be quite complex to understand what's actually developing the EIB within the athlete. But if we purely think, generally speaking, the EIB is driven by a dehydration of the airway surface liquid that leads to an inflammatory process, which leads to a muscle constriction, the bronchoconstriction around the airway. Then we start to think, actually, what we need is a challenge to actually diagnose this, a challenge that offers a big dose of dry air that simulates the dry air that you might breathe during exercise, which is basically what EVH is, and we'll talk about that in a little bit. So effectively, EIB, very similar to asthma. When it's not triggered off, people's airways look very, very, very similar to being healthy. But when it is triggered off, we get an inflammation of the line of this small airways, and we get a muscle constriction around the airway. And so to treat this within an athlete with EIB, it's a case of inhaled corticosteroids to reduce the inflammation, and short-acting beta-2 agonists and long-acting beta-2 agonists to try and prevent the muscle constriction around the airway. And once we've actually detected it and treated it, we can basically have individuals with EIB exercising as if they didn't have EIB, so we can prevent it from occurring during sports. So just going to get on to kind of optimizing the diagnosis and the different options we have. In the UK, we have developed a kind of a testing battery that allows us to basically do 45 minutes of testing with an athlete, and that allows us to really get a clearer idea as to whether someone's got EIB, whether someone's got a disordered breathing pattern, whether they've got laryngeal obstruction, whether there's a nasal problem, or other things that might be causing their symptoms. But when you're a clinician or you're thinking about how we're going to diagnose it, we talked about symptoms. Don't use symptoms alone because they're non-specific. We have to do an objective assessment to really get a secure diagnosis of the athlete's issue. So we think about objective tests, what's available to us. So initially, you want to do some baseline assessments. At the moment, spirometry is kind of the center of that, and so we want to do a baseline spirometry assessment. Now, if an individual's baseline spirometry, their FEV1 is less than 80–70%, you might just go straight away to do a reversibility challenge. And even some athletes, not many, we see that. We offer some salbutamol and measure lung function 10 minutes after that, and we see an improvement in FEV1 of greater than 12% or more. That's sufficient evidence to to provide objective evidence that the individual has reversible airway issues and effectively kind of support a diagnosis of asthma. So we can go that far. Now, majority of young, otherwise healthy individuals, when you measure their baseline lung function, it appears kind of normal. And when I say normal, it's better than 80% of predicted. And they won't necessarily give you that reversibility response following salbutamol at rest. So we need to do some sort of provocation challenge to try and evidence that. And so we have a range of assessments available to us to do that provocation. And there's two options really. You've got what we call direct airway challenges, which you might be aware of, something like a methacholine challenge, and you have indirect airway challenges. Now, in the diagnosis of EIB, and especially in athletes, direct airway challenges aren't particularly helpful because what they do is they directly stimulate the smooth muscle around the airway, and they don't involve the inflammatory process. And so when we look at direct airway challenges, if we're using a direct airway challenge, if you are positive to a direct airway challenge, like methacholine, it doesn't confirm asthma, but if you're negative to it, it rules it out. So if you have an athlete and you suspect they might have asthma and they have a positive methacholine challenge, you can say, well, you might have asthma, but you can't say you might have EIB, but you can't say you have EIB. Whereas with an indirect airway challenge, something like EVH, the three main ones are either an EVH challenge, an exercise challenge, or a mannitol challenge. If you're positive to an indirect airway challenge like that, that confirms the presence of asthma or EIB. But the problem with those challenges are, if you're negative, it doesn't rule it out. So what I'm getting at is there's not a perfect test here. Yeah. So as a practitioner, we need to kind of use kind of a bit of a, it's not just relying on the test, it's also relying on the symptoms and relying on other factors that we know about our athlete to kind of get the best diagnosis. Now, when we look at indirect airway challenges, the most sensitive and specific, or the most sensitive challenge that we have is the EVH challenge. And the reason why it's so sensitive is because what we ask the athlete to do is breathe really hard for 6 minutes, and they're going to breathe air that is around about 2 to 5% humidity. So therefore, it's very, very dry. And we've talked about the pathogenesis of the EIB. It's dry air. It's the dehydration of the airway that causes, or that develops the inflammatory response that then develops the bronchoconstriction. And so the reason why EVH is so sensitive is because of this big dose of dry air that it's going to deliver. And there's plenty of research out there that demonstrates the sensitivity of the EVH challenge. And so when we're in the UK, kind of over 20 years of experience of developing it, our first go-to test to look at athletes that potentially might have EIB is to do an EVH challenge. And so I'll just go through the methods of that EVH challenge, and then we'll demo it for you. So what we need to do an EVH challenge, we need a spirometer, and we need some kit. And so the picture on the top is kind of the old way of making up the equipment for EVH challenges, where we had to make a special mix of gas, and we had to get a sort of flow system so the air would flow through. And the person would sit there and breathe breathe hard, and all the air would go through the dry gas meter to measure the amount of air that they were breathing. Now, this Eucapnic system here kind of does all that for you, so you don't necessarily need to get a special gas mix. You just need a bottle of CO2 and a bottle of medical air, or you can even just, if you're in a hospital setting, you can just draw it from the medical air supply in the hospital. And you also need some salbutamol available, because we're going to try and provoke a bronchoconstriction in an individual, and we don't want to leave them there bronchoconstricted. We need to be able to reverse them. So don't do these assessments without a salbutamol inhaler around, because you might need it to reverse the bronchoconstriction you've just initiated. So the method. I don't know if, the method of an EVH challenge is you perform your resting measurements. Do spirometry. You can add things in like pheno, or we got oscillometry here as well, which I think in the future is probably might replace, or at least be done alongside spirometry initially, but might replace it going forwards. Only proceed to do an EVH challenge if the individual's FEV1 is above 80% of predicted, and they haven't been, if they have a history of asthma, they haven't been exacerbating and going in and out of hospital recently. So don't do this on kind of an unstable asthmatic. It's more of a test for someone who's got, it hasn't been in and out of hospital, and also has got a relatively healthy looking lung function at rest. What you're going to ask them to do once you've done those baseline assessments is you're going to ask them to breathe really hard and fast for 6 minutes. And the target ventilation is 85% of their maximal voluntary ventilation. So if you think about, if you do a CPET test, think about a VO2 max test, think about the breathing rate that someone's breathing at the top end of that VO2 max test. That's what you're asking them to do for 6 minutes. You're going to ask them to sit still and breathe really hard for 6 minutes. Okay? And they're going to be breathing this dry air. The minimum ventilation is 60% of their MVV. Okay, and we can work out these target ventilations by taking their resting FEV1, and if we want 85% maximal voluntary ventilation, we times it by 30. And if we want the minimum acceptable ventilation, we times the FEV1 by 21. And that will give us our estimates of 85% of maximal voluntary ventilation and 60% of maximal voluntary ventilation. The target is to try and do this for 6 minutes. From my experience of doing this, the first minute's the worst minute because the athlete has to get used to breathing really hard, deep and fast, and also get used to the dry air. But once they've got past that, the last 5 minutes are a breeze. So it's not, they're not a breeze, but it's not, it's achievable. The minimum length of the test it should be 4 minutes, and if, for example, an athlete struggled to kind of get their ventilation going, but then manages to do that, you can increase the length of the test up to 8 minutes, but it's not recommended to go past 8 minutes. It's really important throughout the test that the person doing the test gets some verbal encouragement and is motivated to do it. And then after you finish the 6 minutes of ventilation, you measure lung function in a similar way to how you might do an exercise challenge, where you measure it at 3 minutes after you finished, 5 minutes, 7 minutes, 10 minutes, and 15 minutes. And you can measure it all the way up to 30 minutes afterwards. And what you're looking for is a 10% fall in FEV1 after the challenge. Okay? So I'll show you a video of the challenge taking place, and then we'll get this going over here. So this is my setup in Kent, because I set this up before this bit of kit was available, and you can see the athlete is breathing deep and hard. So there, if you think about, maybe they're sort of on that incline on a CPET challenge, that's kind of the breathing rate you're going to get to at the top end of that. They're breathing a special gas. The gas mix that they're breathing is 21% oxygen, 5% carbon dioxide, and the rest of it nitrogen. So it's the same kind of mix of air we're breathing now, but the difference is it's got more carbon dioxide in it. So when somebody's hyperventilating like this, they don't feel lightheaded and they don't pass out. So I've done over 2,000 of these tests, and I haven't had one person feel lightheaded and have to stop. Okay, so it's a safe test to do, but you can see it's quite an involved test. So the person who's doing the test needs to be really motivated. So if I stop presenting there, and then I think Benjamin's gonna be our guinea
for
pig
today.
And Christian, you want to come up and make the
exactly the equipment what you can see here is more or less implemented in this Eucapsis device. So the method is absolutely equal, and we already did a pre-spirometry test. We have the FEV1 parameter available. And the advantage is that you can just set up here in the device the target ventilation, and you can observe graphically on the display how it works. So we just prepare Benjamin. The gas bottles are here behind the device. He will take the face mask on. It looks similar to that what you see on the screen. Only difference is that we do not use a tube to both sides. We just expire to the ambient air over valves in the mask. Yeah, so it means the device itself is set up. You can set up in the device the target concentration, and you can set up the target ventilation especially, and it's up to you. You can hear now it's applying the gas. the reason why it's so big is that this reservoir is included in the device. So this reservoir bag is going to be filled up, and then, just let me start because it takes 5 to 6 minutes, and then I can continue with a few explanations as well. So I'm just setting up the target ventilation, so it's 130 liters per minute for him. Let's start the test. Oh.
Okay. So Benjamin's resting FEV1 was around about 4.4 litres, and so when we times that by 30, we get to approximately 130 litres per minute. So what we tend to do is we set the ventilation target kind of within units of 10, because it's a bit difficult to kind of get specifically to 1 litre. So you can see he's kicked off. See, it's nice, deep, fast breathing.
And you can even look at the screen. There's a small display in where you can see graphically where your ventilation is at the moment, and you can expand the time as long as you want. Recommended up to 8 minutes. I think we do for 5 or 6 minutes today. I think it's enough. It's not the top athlete, just top medium, but you can see it's really challenging. But Benjamin did it several times. Yeah.
Yeah.
It's even counting the time, of course, so you get the information, always the feedback, how long this task already took. And done.
Excellent.
So I just stopped the test. Good.
Hold on, Benjamin. Sarah, round of applause for Benjamin. Excellent. And he lives. It's okay.
He still lives, yeah. Okay. I'll start the countdown right now.
Excellent. So whilst we're just, so you can see here Benjamin's got a bit of a cough, a post-test cough. That's quite normal. So the person's likely to have a dry throat for probably up to 30 minutes or so after the test. But that's about all the kind of side effects you might experience. Obviously, if you've got someone with EIB, they might be now reporting that they have a tight chest or that it's a bit harder to breathe. But as long as they sit nice and relaxed in the chair, we just need to wait for 3 minutes and 5 minutes to capture this drop of 10% in FEV1. Once we've captured the drop, we don't need to keep going with the post-test spirometry. Once you've got the drop, you can offer the salbutamol. So you don't need to keep going. So, and I've just put on the flow loop, so you might expect to see from this is actually kind of quite a mild positive test up here. So the green flow volume loop is at baseline. Then the red dots are around about 5 minutes after the EVH challenge, and then we offer the salbutamol, and you then measure lung function again 10 minutes after that point, and you can see the reversibility. And this obviously gives a nice picture to the individual you're working with. You can evidence the bronchoconstriction, but you can also evidence the reversibility from using the inhaler. So therefore, you get that kind of nice, secure diagnosis that the individual has kind of a bronchoconstrictive response to this test, and they also have a response to the salbutamol, and so you can evidence the reversibility as well. And so that's kind of quite a nice tidy way of capturing everything. I don't know how much time we got on. Are we doing on there? Huh?
Yeah. What?
Yeah. Do you want how long have we got left until we need to do a spirometry? Okay. About a minute.
Yeah. 1 minute.
Okay.
And the first 3 minutes are over for the first testing. So at least it takes 3 minutes prior. You can expect the first reaction, right?
Yeah. So we the reason why we do it 3, 5, 7, and 10 minutes afterwards is because of this delayed response in the bronchoconstriction. The actual act of hyperventilating is actually a bronchodilating. Is bronchodilating. So we need to kind of wait for the effects of the hyperventilation to wear off and the bronchoconstrictions to take hold. You might see, though, if you have a kind of a moderate or severe case, that they constrict kind of almost instantly. But in the mild cases, you might not see it. When we look at the data in terms of when we see the biggest fall in the FEV1, it's usually between time point 5 and 7 is when you see the biggest drop in the EVH.
Okay. So
do you want me to?
20 seconds, so we just prepare.
Yeah.
We switch over to the
I don't know which
spirometry device. So, good. This is now from the coming from the spirometer, and we can do the test. 3 minutes are over right now. Just do spiral testing of flow volume loop.
Therapy for your clients. So a mild response to EVH is a drop between 10 to 20% in FEV1. If you have that, you might initially give an inhaled corticosteroid and a short-acting beta-2 agonist. Inhaled corticosteroids to use on a daily basis, and the SABA to use when required. Moderate drop is somewhere between 20 to 40%. Then you might consider doing a combination of ICS and LABA and a short-acting beta-2 agonist. A severe fall is over 40%, and then you might consider maybe slightly stronger combination therapy with a short-acting beta-2 agonist, and potentially might even consider something like Voluntary as well, potentially, depending on the person you're working with. But the severity of the drop allows you to kind of helps with the prescription. If we think about the benefits of the EVH challenge, it's highly sensitive, it's controlled. We can guarantee the environment. So one of the problems that I had initially when I first started doing work with athletes was initially we started doing exercise challenges, but the problem with an exercise challenge, even though it's very specific, you might have to do the exercise challenge 5 or 6 times to get the right environment that triggers off the athlete. Whereas by doing this challenge, you know you're going to get dry air, and you know you're going to ask the athlete's going to breathe at a high ventilation rate, so you can control both of the environment and the ventilation. It supports diagnosis, and it can also support ongoing management. So you can do this assessment after the individual started using inhalers to look at the impact of the inhaler on their asthma severity, and it's less disruptive to athletes' training. So, for example, I'm going to go and test the British Paralympic swimmers tomorrow with this test, and they'll do the test and they'll quite happily train in the afternoon. So, whereas in an exercise challenge, it would kind of wipe them out for the whole day. So it fits better. But as with all tests, there are some cautions. So one of the issues is it's not progressive. So you do 6 minutes of ventilation. Somebody might drop 10% or 15%, but somebody might also drop 60%. So you might have quite big drops in lung function, and that is why we don't do this test with unstable asthma or with people with abnormal lung function at rest. People do get a kind of a persistent cough for around about up to an hour after the test. It is less relevant for non-athletes, but it's still a test that they could do, depending on what triggers off the symptoms. And sometimes it is argued that the dryness of the air isn't necessarily replicant of the athlete's environment, because most athletes don't compete in kind of 5% humidity. They're usually kind of 20% or above. So there are a few things with the interpretation, but it's still probably what is definitely the most sensitive test to do to diagnose EIB, and because of that, it means that you don't need to do multiple tests. Just one good test is usually good enough. And so just a few things to go through. This is an example of how you might use it as a pre and post therapy. So this is with one of our GB swimmers. When we tested them in 2014, they had a 38% fall in the FEV1 off therapy. We then tested them in May of that year once they'd started combination therapy, and we tested them whilst they were using the combination therapy, and then you can see the impact of that therapy. So instead of having a 38% fall in their FEV1, they're having a 7% fall whilst they're using therapy. So the athlete's really confident that that inhaler is supporting is improving their airway health, and if they use that inhaler appropriately, they shouldn't need to worry about experiencing EIB whilst they're in the swimming pool training. And so therefore they can train as if they didn't have asthma, basically. So this is quite a good way of kind of monitoring therapy as well. I'm skipping through slides now because I know we're short of time. It is the repeatability of the challenge. Again, this is data we published about the repeatability of the challenge. This is kind of year-on-year testing that we've done with our swimmers recently. It's got a good repeatability to it. This is just a bit of data around prevalence. I'm not going to go into that too much because we're kind of out of time. But I just wanted to highlight a few things. So we have used it as screening. So we have gone and screened athletes for EIB, and that is quite important because a lot of athletes fail to recognise kind of maybe what experiencing a tight chest. So when we screened athletes for EIB in the UK, we found the prevalence across these sports of 34%. What's interesting, though, if you look at the drop in FEV1, you can see that the drop anything below that red line is a positive test. The dark circles are the athletes that had a previous history of asthma before we screened them, and the open circles are the ones that didn't realise they had any asthma or EIB. But you can see some of these athletes that didn't realise they had EIB, and these are elite athletes in the UK. Some of them are dropping quite significantly. We've got one athlete there who's dropped 60% after an EVH challenge and hasn't realised they got an EIB. They just sort of finished the test and went, oh, feels like I've done a training session. Then we measure their lung function, and their lung function has dropped 60%, and they just thought that tight chest after training was normal, which it wasn't in this case. So it is worth kind of screening groups of athletes if you have the ability. We've also done it in recreational level athletes and had similar, and it's tolerable in recreational athletes as well. And what we do see when we do screening in elite athletes and we track their respiratory health, we see reductions in severity. So this is some data that we've had from some English football, so some of the Premier League and Championship level football players. When we screened them, we found the prevalence of around about just short of 30%. But when we actually monitored them on their treatment, we saw reductions in FeNO, so we saw reductions in their airway inflammation. Once we treated them, we saw reductions in their response to the EVH challenge, so we know that their asthma or their EIB severity is improving. But we also saw improvements in their VO2 response. So basically, detecting someone with EIB improves their VO2 to a point where they're equal to a non-asthmatic. And so if we don't appropriately detect athletes with EIB, they are at a disadvantage when competing against athletes who don't have EIB, whereas if you detect them, treat them appropriately, they then, their VO2 responses are similar to non-asthmatic athletes. And that is the whole point of making sure we get these assessments appropriate, is to detect them, to manage their issues appropriately, and then allow them to compete on a level playing field with non-asthmatic counterparts. And just within this book, this is kind of where management of respiratory issues with athletes kind of fits, is because it's not just asthma that we need to consider when we're looking at asthma. So when we're looking at respiratory issues. So the EVH challenge is kind of the central part of that. So which is kind of why I've kind of got this kind of red box around this particular part. But if, for example, Benjamin, who did the test, was negative, that helps us out, because if he's reporting symptoms, we can say that those respiratory symptoms aren't related to asthma, and it might be a disordered breathing pattern, it might be a laryngeal obstruction, so we can go and investigate that, rather than throwing an inhaler at him and going, well, come back in a year's time and let us know how you're getting on. And so we can be more reactive for the athlete to help them out and get them that response. The other thing is to also be aware that these respiratory issues don't happen in isolation. It's quite often that we'll have an athlete that might give us a positive response to the EVH challenge. We then treat them with an inhaler, and then their EVH challenge is good after they've used their inhaler, but they're still reporting symptoms. And that then might mean that they then need to go and do some investigations into disordered breathing pattern or laryngeal obstruction. And it's quite common that those two conditions go hand in hand together. And so by using this type of assessment allows us to make sure we don't over-treat athletes. So we don't just put them in a box of every time you're breathless, it's because you're asthma, so use more and more medication. It's about giving them the right therapy and allowing them to go and be the best that they can be. And from the point that I'm talking about an elite athlete there, but that could also be a recreational level person just being able to enjoy sport without getting out of breath as well. So there's all of that to consider. So I'll finish there. I'm going to hang around for a little bit. So I know we've thrown quite a bit at you. I'm going to hang around if you want to have a chat about any of this type of testing. More than happy to do that. But thanks for your time. And I'll see you around the conference. Bye-bye.